Thank you so much. It's a pleasure to speak to everybody about this today. These are my disclosures. Perfusion assessment, as we know, the traditional way is difficult, it's subjective, it's not reproducible, and we sort of have called it cut and bleed as essentially IC blood. ICB is what that's the Twitter term for it. Can we use technology to assure perfusion? That's the question of this talk, essentially. And if you look at this, is actually old pictures from way back into 2010s. You think that the arrow is kind of this line where the arrow is where white light, we were going to transect this. This was going to be an intracorporeal double purse string case. And then you turn on ICG, and below and behold, there's a centimeter of colon that's essentially not perfused. Then the question becomes, does this make a difference or not? And I think that's what we're going to try to answer. And given the fact that we have a broader audience than colorectal, we're going to really focus on perfusion in this talk, but mostly we're going to look at the anastomosis, revisions, and diversions, because the data for everything else in general surgery is not very robust. But it's important to know that the use of ICG fluoroscopy, whether it's handheld or laparoscopic, is growing vastly among all of general surgery, plastics, and even orthopedics. The only randomized clinical trials really are on colorectal anastomoses because it's easy to design these trials and it's easy to study them, and we have a high rate of leaks. So let's review the data. I think it's important to realize that we, at the beginning of the ICG, induction of ICG, essentially, when we had SPY, we were very excited about it because when we did our phase 2 trial looking at colorectal anastomoses, these are mainly within 10 centimeters, not rectal cancer alone, we found very low reek rates. 1.4% is really much lower than the average reported within all the traditional trials. We did find that at this time there was a 19% change in resection margin due to ICG fluoroscopy. Did this lead to a lower anastomotic leak rates? That was our hypothesis, and hence essentially the next 10 years, everybody started doing phase 2s and retrospective studies, and I'm not going to waste time because we have so many clinical trials now that what you need to know is that ICG fluoroscopy in all of these systemic reviews were shown to decrease anastomotic leak rates. So let's go to the randomized clinical trials. There's really 3 of them that we should talk about. This is the US Pillar 3 that was published in 2021. And essentially, it was a multi-institutional trial with a mid-trial reassessment that never reached power because it stopped accruing. And what I want you to realize from this trial is that the US population is very different from the European and the Asian populations in that we use about 65% of our patients had low chemoradiation. This trial was only for rectal cancer, and essentially anastomosis less than 10 centimeters with a mean anastomosis of essentially 5.2 centimeter in both arms, and essentially everything was similar between the 2 groups, and we had good visualization. And this is a couple of laparoscopic technologies behind from where we are now. What we found is that anastomotic leak rates are essentially the same. So it did not make a difference whether we used ICG or not. And when we did a tipping point analysis, because obviously we hadn't reached power, even if all the patients had leaked in our control group, we still would not have reached statistical significance. You can argue whether that would be clinically significant, given that it would be 14% versus 9%. So the conclusion of this study was that ICG does not decrease anastomotic leak rates, and we specified that in high volume hands because obviously the surgeons that are participating are all high volume surgeons. The Italians also then had performed a trial sort of published in 2020, and their chemoradiation rates were about 20%. Their change in transection point was 11%. Pillar did not capture it because we didn't know what it meant. And the anastomotic leak rates were low at 5 versus 9%. And they again said that it does not decrease anastomotic leak rates. And we don't really know what the 11% change in transection margin means at that time. This is a trial out of Russia, the FLAG randomized clinical trial, published around the same period. Again, I just want to bring your attention to the fact that chemoradiation in this group is about 10% across arms, and they did a higher anastomosis. They looked at 15%. And they looked at their anastomosis basically low and high, and they defined that at 8 to 15 centimeters and 8 centimeters. Overall, what they found was that anastomotic leak rates were lower in their ICG group compared to their control group at 16.3%. However, when they did a subgroup analysis, that did not make a difference, obviously, for the higher anastomosis. So there's something different for the lower anastomosis from a biological and technical standpoint, and we already know that. This really is the trial that I think that we should all, it was very well designed, a Japanese trial. They designed a superiority trial with an expected 8% decrease in anastomotic leak rates. They further specified good perfusion and poor perfusions. Now, they picked the 60 seconds based on a study that arbitrarily picked the 60 seconds, but the thought was, and that some studies say that like if it's more than 60 seconds, you should take more colon. So they essentially revised their margin by 1 centimeter if the perfusion was visualized 60 seconds afterwards. Again, same, it's about 10% of chemoradiation, and the level of anastomosis was similar to Pilar, so very similar in that aspect with the exception of the rate. And then as is the Asian trials, they don't do very much mobilization of the flexure. So what they found essentially was that they did have a decrease in anastomotic leak rates of 7.6% versus 11.8% in their control group. The issue is that they had designed a superiority trial and they never reached superiority. So it just depends on how strict you want to be with this trial. At the end of the day, they had a statistical significance with the decrease of their anastomotic leak rates. I was really interested because this is the only trial that you could figure out what was going on with the additional transection margin. They have good data about that essentially 10 patients, 2.4. So you think, okay, so if all these patients leak, then maybe there would be a difference. So did ICG really change it? Of those, one of those patients leaked, and I think further than that, we can't really say anything. And why? I don't know why. If anybody figures it out, please let me know. I mean, I have theories, but nothing proven. And I then further wanted to see, okay, the population in the Asian and like the Europeans is different than the US because we use a lot more, especially long course chemoradiation. Does that make a difference? And when you look at the anastomotic leak rates in their patients who've been radiated, it's essentially, it's not significant. 13 versus 6% with the numbers weren't very high. So it's interesting. And they actually looked at this, like what are the independent risk factors for a leak? And the most common is chemoradiation and obviously height of the tumor. And we know that because we know that chemoradiation both changes the microbiome and the vascularity of essentially your rectum. And from all the studies, including Pilar, when we were looking at them endoscopically, your rectum stum is usually never the issue with perfusion. So you fix the perfusion proximally. What that microvascular means distally, I don't know the answer to that. And this is kind of like what you want to think about. This is the handheld device. Good visualization and confirmation is important. Whether you use it or not is something that we can talk about. These are ongoing trials. Actually, the ENACT trial, it's coming out. So it'll be very interesting because they included microbiome data in it, and I'm very interested to see what they found. I think they might be presenting it somewhere soon because they're basically they finished up. Since it's a broader audience, I did want to touch on foregut. Not any randomized clinical trials, but the 150 patients that the Demeester group kind of looked at back in 2015 was around the same time that we did Pilar 2. And esophagectomies are different because for colon, I can always take a couple more centimeters. I mean, and then if I hit the marginal, then we can figure something out. You got a lot of colon, but you don't have a lot of stomach to pull into the chest, et cetera. So it's a much different thing. Like you can't, like what are you gonna do if it's not well perfused? So they looked at their well perfused and less well perfused, and they put stitches. That's how they figured it out. And when they looked at their leak rates, it was only 2% in the well perfused and 45% in areas of less perfusion. And this is like a no-duh, no-brainer kind of moment, but it's like, what are we going to do about it? And I think that the foregut surgeons have a much more difficult decision-making process than the colorectal surgeons for sure. And the patients that did leak in the good perfusion had minor leak as opposed to major leaks. And then there was a good meta-analysis that was done that looked at 381 patients essentially that had ICG in these like sort of level 2 evidence type of papers, and then they looked at historical, like Ivor Lewis esophagectomies that had been published over a period of time, all minimally invasive, and their anastomotic leak rates were the same. So again, like everything else, the data is inconsistent with no clear path forward. So, and we'll talk about that in a bit about how to manage that in your own practice. I did want to touch a little bit on emergency general surgery, and if you think about it, this is where the gray area is, and this is where I personally think, especially for someone who doesn't take that much general surgery call, I mean, I get called into stuff, but I don't take it. The general surgeons on call do handle a lot of this stuff, and there's a lot of subtlety, and you have to sit there and figure out, is this gonna live, is this not gonna live, take backs. Is this a type of technology, especially as we move from just subjective qualification rather than quantification, will it be a day where we can point it and know it's going to take us oxygenation and tell us whether it's going to live or not, so we avoid second look surgeries for people who are potentially for that? Can we avoid stomas in a subset of patients because perhaps that surgeon doesn't do as much colorectal, et cetera, if they have something? And will that eventually lead to decreased costs and decreased complications, which I think is the most important thing that we have to ask about the ICG, and we've been so far focusing on anastomotic leak alone without looking at the consequences of cost of the leak itself. I did want to touch a little bit on depth and timing. This is the issue, I think, with ICG fluoroscopy, is there's still a learning curve for it. It's not a yes or no, because I'll watch the residents do it. Like the optimal distance is said to be 4 to 5 centimeters, but if you have blood in the corner, that's taking up your light, so surrounding light makes a difference, your emission source makes a difference, and for those of us who do a lot of laparoscopy, you get a camera. Half the time it looks fuzzy, half the time it looks good. You can't understand why because they just upgraded all the systems, so you all deal with all this stuff, and this is definitely something that adds to it. And then timing is very, very subtle. Studies, there was a study that defines it, and it says 30 versus 22 seconds. I don't know about you, I can't. That's very, very close, and it's really hard. And then what do you do if it's more than 30 seconds? Do you not anastomose the patient? I don't really know. And then suggestion that anything over 60 seconds really shouldn't be anastomosed. I think it's a very broad suggestion, but it's something that you should consider. If you're sitting there waiting for it to come, you got to figure out, did they not flush it? What do they do? And these are all, it's a lot of essentially learning curve issues with the ICG fluoroscopy, like everything else we do in the operating room, and that's where volume, et cetera, really helps. Again, pros, it's cheap, it's ubiquitous. Essentially, everybody has it in the operating room now. It's easy to administer, it's not time consuming, but it can be subjective. You still have learning curves, just like white light, and there's inconsistent data essentially across the board, even with a randomized clinical trial, so it's very confusing. I think the most important thing about ICG is it makes you stop at the most critical portion of your operating room. It's like when you do an endoscopic evaluation. It makes you stop and really think about that moment and that perfusion, and it does help make you make a decision point. But I do think that it's difficult to really have a lot of randomized clinical trials because you also have very high volume surgeons in those trials. So you have to take everything with a grain of salt, and you have to use it as a tool. Endoscopic evaluation, I think we did this in Pillar. We don't really know, if there's no perfusion in the mucosa, what do you do kind of thing? Is it more likely to leak later? I think those are important things that need to be answered in the future. Oh, I forgot that I gave it that. Okay, so is it hype? I don't think it's hype. I think it's a tool, and you have to know what the limitations of that tool is and how you're gonna use it in your practice. And some people use it all the time. Studies have shown about 70, most colorectal surgeons use it about 60 to 70% of the time, the high volume ones, and then there are those who don't use it at all. So you have to figure out when to use it and how it's going to fit into your practice based on the literature right now. That's it, thank you.